my Kalina Arji, and I'm going to present an evaluation of the psychological, social and biological explanations for schizophrenia. Then I'll give an analysis of the problems in assessing the effectiveness of treatment for schizophrenia. Schizophrenia is a mental disorder causing a wide range of different symptoms that could be attributed to other mental health conditions. As a brain disorder, it causes fragmentation patterns of thinking, distorting thoughts, emotions, and altering how those affected perceive people responding to others and their perceptions of reality. Approximately 1% of the world is affected. It has been seen that 48% of sufferers have recovered from this disease over a 25-year period. The DSM-5 criteria for schizophrenia include symptoms that have persisted for 6 months. The ICD-10 requires these symptoms to be presented for only 1 month. The criteria are the following. Positive symptoms. These may show up later in life, responding better to drug treatment, which suggests biological processes and chemical processes happening, known as type 1. Negative symptoms. These generally start earlier, more likely from affected brain structure, and therefore they're less likely to respond well to drug treatment. This is known as type 2. Positive symptoms include delusions. These are an unshakable belief in something that isn't based in reality, but not necessarily unrealistic. For example, believing they are being poisoned, conspired against, being loved by someone who may not be loving them. Another type of delusions are bizarre delusions, where they believe they have been abducted or cloned by aliens. Hallucinations, hearing voices, smelling sounds, experiencing tastes, all of which are not really there. Disorganised speech, making verbal communications incoherent, shifting from one topic quickly to another with no connection, repeating words and statements. And grossly disorganised behaviour, having problems within daily living, but having no goal-directed behaviour, with lack of social inhibitions, strange behaviour that is odd to onlookers. Negative symptoms include catatonic behaviour, sitting or posing for long periods of time, lack of emotion, lack of motivation, speaking very little or without providing coherent information. There are 3 approaches for the psychological explanations for schizophrenia. There's behaviourism, psychodynamics, and cognitive, and all of these have an impact on the onset of the symptoms. Behaviourism is the theory that all learning is based on conditioning, which occurs through the interaction with everything around. It is our responses that shape our actions. An example is rewarding a child in school for doing their homework so they do their next homework, called operant conditioning. Classical conditioning is shown with Pavlov's dogs, who learn to salivate when they hear the bell ringing before they get their food. In other words, behaviourism assumes that the things we see and observe are the only things that are real, and that is the only way we learn. But behaviourism ignores that the environment alone does not shape the person. We have free will, our own internal processes, and we are active in our learning, unlike animals. Bateson's double-bind theory is where instructions given to someone contradict each other. For example, a parent is appearing angry but is expressing love. The verbal and the non-verbal communication are in contradiction. Children brought up in this type of atmosphere are more likely to develop schizophrenia, as it develops in them a confusion of reality. However, not all children brought up like this develop schizophrenia. The psychodynamic theory is Freud's. He says that abnormality of behaviour is caused when there is unresolved conflict between the id, the ego, and the superego, which is then repressed to the unconscious mind. He believes that the child's early development could cause schizophrenia if any of these stages are interrupted or contradicted. The id is the impulsive and unconscious part responding to basic urges, needs and desires. The newborn until 2 is all id, needing all its desires satisfied immediately. The ego is the decision-making part of the personality, reasoning with the id to make compromises, rational and problem-solving. For people with schizophrenia, the ego has problems distinguishing between the external world and the self. The superego, controlling the id's impulses and engaging the ego to strive for perfection. According to Freud, for someone with schizophrenia, the person has regressed back to a childlike state where the id is in control, and so the ego doesn't function properly, causing confusion between reality and fantasy. He was not acquainted with neurochemical abnormalities, basing his theories on the libido as the driving force of all behaviour. If Freud had lived several more productive years, he would have been able to give a more rational explanation for schizophrenia. The cognitive approach focuses on how we think, assuming that our behaviour is affected by our thought processes. This approach examines how people think and how they process information. Cognitive symptoms of schizophrenia include disorganised and slow thinking, difficulty understanding with poor concentration, as well as difficulty in expressing and integrating thoughts, feelings and behaviour. Frith's neurological theory of schizophrenia is the neurological impairment, the theory of mind, TOM, which is the ability to understand the mental states of others, to correctly interpret others, which schizophrenic patients do not have as they make up their own stories. Discrepancy in neural connections gives rise to auditory hallucinations as they believe their own thoughts are coming from someone else. This links the psychological understanding with the biological reasons of schizophrenia. The social explanation emphasises the role of the social situation. Is the lower class more vulnerable to schizophrenia? Does the lower class have more people with schizophrenia? Why do people with schizophrenia tend to be found in the lower classes? A case study controlled by Fiona Mulvaney, a researcher and professor O'Callaghan, in 2015 found that the risks of schizophrenia were not increased in low social classes, but those in high classes presented for treatment sooner and were more likely to recover, as treatment delay can cause an adverse outcome in the psychosis. However, being in a lower social class brings with it higher populations living together and potentially higher unemployment, increasing stress levels. Those vulnerable genetically can have schizophrenia triggered in these conditions. R.D. Laing, a Scottish psychiatrist who wrote extensively on mental illness and believed madness was a sane response to an insane world, as quoted in The Guardian, believes it is caused by social pressures from life and is a result of the types of interactions between families and other people. In summary, he says schizophrenia was down to poor parenting. Rachel Cooper evaluates Lang's claim that schizophrenia was not reflected in biological dysfunction or even psychological dysfunction, but stemmed instead from external problems like the family, that schizophrenia is not in the patient. An example is given where a woman believes people are making signs and talking about her behind her back. When the psychologist visited her, he saw that the parents were indeed nudging and winking to each other, and the patient's claims were valid in the home environment. So Lang believes it is caused by social pressures from life and is a result of the types of interactions between families and other people and has nothing to do with class. Possibly undiagnosed schizophrenics, as well as diagnosed schizophrenics, commonly lose their jobs and end up victims of social drift, moving to poorer areas as their standards of living deteriorate, losing their jobs and thus increasing the higher rates of schizophrenia found in the lower social classes. PET scans of people with schizophrenia show underactivity in the frontal lobe of the brain. This part of the brain is linked to self-monitoring. We have neurotransmitters and dopamine hypothesis, and we have the genetic explanation. Neurotransmitters are chemicals in the brain that travel between brain cells called neurons. Neurotransmitters bind to dopamine receptors in the receiving neuron via dendrites, and they transmit their messages forward. Arvid Carlson in 1967 discovered that the neurotransmitter dopamine and came up with the dopamine hypothesis. He noticed that a lack of dopamine triggered Parkinson's and saw that overactive dopamine levels can cause schizophrenic symptoms when drugs like L-Dopa are given to patients with Parkinson's disease. Dopamine is recognised as regulating mood, motivation, reward and attention, and is known to be partly responsible for the type 1 symptoms of schizophrenia. However, what is not known is whether it is too much dopamine that triggers schizophrenia or if there are too many receptors of dopamine in key areas of the brain. What has been seen is an abnormal ratio of dopamine receptors subtypes D1 and D2, and as these receptors are responsible in maintaining accurate representations of the world, then an imbalance here can cause delusions and hallucinations. However, also known is that angel dust, also known as PCP, inhibits glutamate receptors, and when affected, those people show similar symptoms to schizophrenia. As dopamine also inhibits glutamate synapses, exciting the neurons that inhibit dopamine, it is uncertain as to which neurotransmitter is actually involved. Amphetamines increase dopamine activity and users produce schizophrenic-like symptoms. It is still not clear which neurotransmitters and neuroreceptors are involved. Drugs which affect type 1 do not affect type 2, the negative symptoms, and some of the neurochemistry is still unclear. Some patients also do not respond to drugs which block dopamine, so it would seem there are other neurotransmitters involved other than dopamine. In conclusion, dopamine is not the only factor in schizophrenia. It is not possible to measure it directly in a living person, so the evidence is based upon assumptions. This hypothesis does not take into account the whole biological processes of dopamine. And finally, it is evident that genetics play a role in schizophrenia. A study led by Stephen McCarroll found that in the brains of people with schizophrenia there was an increased expression of the C4 gene, and that the brain connections of people without schizophrenia have more brain connections than those with the disease. C4 is a gene telling the immune system what to attack. It marks out infections. C4 is involved in synaptic pruning in teens and early 20s. This is when unused synapses get removed as the brain grows into an adult brain, and the lacking of C4 can send that process into overdrive, giving a higher risk of developing schizophrenia. Symptoms often appear after adolescence and their brains show fewer synapses. We can also see here in this graph that identical twins only stand a less than 50% chance or 1 in 2 ratio of being schizophrenic, where one could be affected and one not, which suggests that this illness is not entirely genetic focused. In other words, one can get it, but another may not get it. This shows that there are other factors which can change the likelihood of developing schizophrenia, maybe like the environment. This also includes high stress experiences in life, birth complications, one twin may have it easy and the other not, drug use whilst in teen years during the fast developing brain. The environmental impact itself can change the chances of developing schizophrenia. Dr. Daniel Weinberger, in his 2004 presentation, stated that there are estimated to be 10 genes associated with schizophrenia. And even though we all have these genes, those with a number of variations are more at risk of developing schizophrenia. He found that when the gene called COMT is abnormal, hallucinations can happen due to the neurochemical dopamine being depleted in the frontal cortex and affecting the brain's reality check. Several genes are seen to be implicated, yet none are fully responsible for the disease. A person who has all the genes implicated does not always necessarily develop schizophrenia. It is clear that environmental factors play a role in triggering these genes, and that a person with more variations of these genes then have the higher the risk. It is important to note that genetics are not fully responsible for schizophrenia, otherwise identical twins would suffer the same. There are a less number of genes than originally thought due to the Genome Project, and now that we know that genes play multiple roles, it becomes clear that there is no one gene that causes schizophrenia. Schizophrenia is a brain degenerative disease, and this can be seen with CT scans which show enlarged ventricles in the brains with sufferers. Damage in many areas of the brain include a smaller volume in the hippocampus, which is responsible for transferring information from short-term memory to long-term memory and for spatial awareness, so damage results in mood impairment. The amygdala, perceptions of emotions such as anger, fear, sadness, and stringing memories to recognise for similar events. Damage could cause people to take bigger risks. The thalamus, damage disrupts the information flow from region to region of the brain. Damage to these areas of the brain above can cause some of the catatonic behaviour seen in type 2 schizophrenia. Weinberger studies have shown that people with schizophrenia have less activity in their prefrontal cortex. The reduced volume of grey matter in the prefrontal cortex correlates with hallucinations. Damage causes difficulties with problem solving and impoverished thinking, as this part of the brain is used for logical thinking. With its reduced usage power, then those with this damage will exhibit disorganised patterns of thinking. Damage in other areas include the intracranial space. Sufferers also display a larger pallidum, and with larger ventricle volumes, they are losing brain tissue up to 3%. Prenatal influences can also affect the development of the infant's brain, but these influences cause a problem only if there is a genetic tendency. Identical twins may not both go on to develop schizophrenia, even if there is a tendency to do so. Many different factors are considered from illnesses the mother gets during the pregnancy, different placental sacs rather than sharing one, getting more nutrients than each other in identical twins. In summary, the structure of the brain is affected by many different variables. It is seen that there are structural changes in the brains of those with schizophrenia, but how these structures change is still not certain. Clinicians face many challenges when assessing which treatment is appropriate for their patient. These include maintaining cognitive function and well-being as best as is possible, long-term control of the symptoms and preventing relapse. Compliance of the patients with schizophrenia is important when taking medicines despite any side effects they may have. However, sufferers very often do not believe they are ill, and when they are feeling well, usually because of the medications, they can stop taking their medicines. It is important to remember that medicines do not cure schizophrenia. They can settle the symptoms at best, and sufferers will have to be on these medications for the rest of their lives, which poses a challenge as they feel well and take themselves off, usually relapsing into schizophrenic symptoms once again. Non-adherence is a problem for the clinician as it increases the risk of relapse and ultimately hospitalisation. Intervention can include injecting the medication as well as electronic reminders, but all must take into account the individual patient. Non-adherence affects the patient's outcome, and the clinician has to consider all these factors when prescribing. This will more than likely involve a combination of both medication and psychotherapy. The objective of treatments is to make the patient well enough to be able to live with their condition without needing hospitalisation. There are different types of treatments available. These include biological and non-biological therapies, as well as electroconvulsive shock therapy, known for short as ECT. Non-biological includes psychotherapy, CBT, meditation, mindfulness, and even yoga. The side effects of many of the medications for schizophrenia can be life-threatening and need to be measured against the severity of the illness versus the severity of the side effects. Not everyone has the same levels of side effects, but they can lead to different life-threatening disorders. While some drugs are known to work on the dopamine levels quickly, their good effects may not show up for weeks, and most work effectively for up to 6 months. There are typical and atypical drugs. The typical are the older style and are being replaced with the newer style. Some of the side effects cause problems for the practitioner in deciding which are most appropriate for the patient. Side effects include tachycardia, which is increased heartbeat, drowsiness, changes in heart rhythm, weight gain, high blood sugar, tardive dyskinesia, cataracts, increased anxiety, agitation, and headaches. Some drugs are so intolerable to some patients that they cannot bear them for more than 6 months. All these side effects cause problems for the clinician in choosing which medication is the most appropriate. Some can be taken by injection, which, if the patient is willing, is easier for the clinician as this guarantees the medication is being taken. Medication can be taken orally or by injection. Neuroleptic drugs, also known as tranquilizers or antipsychotic drugs, typically affect the dopamine levels on the D2 dopamine receptor. The atypical drugs target serotonin as well, with less impact on the D2 receptor and greater effect on other neuroreceptors. Whilst both types have differences in their effectiveness, both types reduce schizophrenic symptoms with no difference in the efficacy. However, not all medications work for patients. Some medications do not respond in some people, and the negative symptoms are harder to treat with medication than the positive ones. Ultimately, the clinician has to consider whether the side effects are too disastrous for the patient. With a non-compliant patient, the therapist can struggle to get them to take an alternative drug if the one being prescribed is too unbearable for the patient. Electroconvulsive therapy, ECT, is effective if there is acute depression as well. Its nuisance side effects include headaches, nausea, and muscle soreness in the afternoon of the treatment, which may even extend into the next day. However, it has a poor image. Pictures of One Flew Over the Cuckoo's Nest come to mind. With this, many clinicians shy away from this treatment, and patients may be too fearful of it, even though it is dramatically executed differently. Yet this picture and the whole film is etched into the brains of generations of movie watchers, influencing our own reactions to ECT. Psychological treatments or non-biological therapies are effective for working alongside drug therapy. Patients can become aware of their unusual behaviour or the lack of skills through regular sessions, working together with their therapist toward goals that make the patient more acceptable in society. Role play can help the patient learn verbal and non-verbal skills, as social modelling shows the patient how to behave in a desired way, and a patient can then copy this. CBT is cognitive behavioural therapy and has proven effective in schizophrenic patients. It challenges negative thoughts and also practices new ways of thinking positively. All these alternative non-invasive forms of therapy are lengthy and costly, as it takes a long period of time for patients to learn some very basic ways of being acceptable within society. The clinician needs to take all this into account when working out the recovery path for their patient. If the patient doesn't like the therapist, this type of treatment won't work, so a rapport and trust is needed from the patient to the therapist. Therapists need to be empathetic to the patient, and mutual trust is required. It is a lengthy process. This type of treatment is effective with positive symptoms only. It does not have an effect on the negative symptoms. Ultimately, any cognitive therapy is not long-lasting, but does help impact on the patient's life during the process. The delusions and the hallucinations will not go away with this therapy, but it does help the patients be aware of their actions. Non-pharmacological treatments are evolving and are effective when used alongside medical treatments and not in place of. They can help fill the gaps, ensuring patients continue adhering to their medication. Some therapies help educate the patients in the dangers of non-adherence of their medication. The clinician's task is to find the right non-pharmacological treatment for their patient. This takes time and can be costly, but ultimately finding the right treatment where both patient and therapist are working well together will bring the best results that can be hoped for. Leave it.